further. We have few people here, but we'll go for the neuroendovascular field. And so it's my pleasure to announce Menka from Skopje, Macedonia. Menka, please.
Thank you. Thank you for the invitation, Dr. Nuri. I will talk today for a little bit talk and more cases I will show you about the tips and tricks in neurointervention in a hemorrhagic stroke. I have nothing to disclose. Endovascular treatment pearls are advanced strategies and complication management in treating of intracranial aneurysms, AVMs, and AVF. As we all know, aneurysm strategy need to be done before the intervention. For wide neck bifurcation in acute stroke, we should avoid stent if it's possible, prefer balloon remodeling or double microcatheter, consider VEP if the anatomy is ideal, and for small ruptured aneurysm, undersizing of the coil and accept neck rembrand. For blister aneurysm, look for delay treatment, for example, when it's ruptured, and not only flow diverter, but together with the coil, if it's ruptured. For flow diversion, technical pearls are anticipate foreshortening in the tortuous siphon, open distal end if it's possible in the straight segment, and ensure full expansion with a recross through the device or balloon angioplasty. Avoid overlapping the critical perforators. Always to be prepared about in the setup of procedural aneurysm complication when it's coming word of thrombus, increased ACT, intraarterial GP, 2B3A, balloon up immediately, reverse heparin, rapid coil packing, and do not pull system unless it's necessary, don't panic, etc. And in massive rupture, consider ventricular drainage early. For AVM, I can say that we should avoid curative intent in deep, eloquent, high-grade AVMs. We should embolize target weak point or flow-related aneurysms and high flow fistulas component. Don't touch the diffuse needles with multiple deep perforators. And philosophy about the liquid embolic materials, not only onyx and the others, to avoid, to control the venous site. Conceptually, first avoid early venous penetration and reflux more than 2 centimeters, and slow control injection with pauses. When it's coming a word of intraprocedural rupture in AVM, arterial, continue embolic to seal the, if it's possible, and venous rupture, abort quickly. High-grade management of the dural AVF, we can say that cortical venous reflux, if it's present, treat aggressively, and for high-grade Conyart-Borden AVF, dural AVF, transvenous approach often is definitive to avoid chasing multiple feeders from arterial side, and transarterial. Always be aware of danger zone. I will show you some cases where we have used some tips and tricks. This is simple. This is case with a simple coiling of the ruptured ACOM aneurysm, where after the dense filling, we can see the a little protrusion of the coils in the A2 from the right side, and thrombus formation. That's the third video, I think. And here we wanted to put the Scepter Mini balloon but because the microwire is 007 inches, and it's very soft, we couldn't pass the protrusion of the coils, and we used another technique that in the moment was familiar to us. We put a microcatheter and microwire 14 Traxes and microcatheter, and with that we opened a way to advance the microwire from the Traxes Mini and balloon, and we made it balloon angioplasty, and everything was okay. Second case is about positioning of the web. Even if we are choosing the right dimensions, the right sizes, it's not always possible to put it in a right way, or how to say, it's a wide neck aneurysm. And we incorporated two of M2, and the first we couldn't open properly. That's the second picture here. Oh, I cannot show, I don't know, here. And this is the good. Why it's not, I don't know. The film is not going. I wanted to show how to see. This video is not going. It's about the pushing, pulling technique.
We can ask them to push it.
The previous, this film.
Next one?
Next one.
Probably.
When opening and pushing, okay, we can use technique and be slowly and gently. And when we are detaching, this video is good. When we are detaching, we should go again with the microcatheter to push and to have this form of the web to stay in the place. And we succeed after a little bit more. You're playing with the microcatheter and the wire from the device, and we get the good result and the finish. This is the same, but here I wanted to point. It's a patient with 4 aneurysms, and these two are a flow dependent one of another. It was a challenge to put this web in this pericalosa aneurysm because of the angle from A2 to the aneurysm and the small neck. We succeeded in that by this technique, pulling, pushing, and everything. And we have immediate stasis, but after that we go to the flow-dependent aneurysm on a media of the MCA. It's look very easy, but after positioning the second web in that in this second aneurysm, it's a zoom image. When we have unzoom image, we can see that after placing the second web, where is that? It was tricky to position this, okay, and this is maybe, yes. We can see that we have a slow flow in one of the branches of the pericalosa, and after that, we give the intraarterial GP2B3A, and we trying to position better this web. We can see that after the recanalization, or it is flow dependent spasm, I don't know what is it, on a pericallosal branch, we have a thrombus on MCA, on the M2 segment, at the second web, and we put the balloon, and now the two webs are okay, and the flow in all branches. I think that was flow related because of the stasis when we go with the microcatheter in the MCA for the anterior. From the same patient, the third aneurysm that was done with the balloon, assisted coiling, and here nothing special in that aneurysm, but this is in the second session, the third aneurysm, fourth aneurysm that we treated, and we was planning to put VEP here, but it was the device that we have on a shelf, it was bigger, and we decided to go stent-assisted coiling, but here I wanted to show you the tips, or how to say, trick to position a good the stent, because you are pushing at the curve and making ballooning of the stent to seal all the neck of the aneurysm. That's my trick, or something, how to say. And we can see the good position here when it's sealing, not to feel from the A1. This is the case with a very tortuous anatomy. We go with radial access because of the because we think that is better, because the brachiocephalic trunk was very tortuous, more than this, and we have to advance this long sheet neuron max deep in the vertebral artery, and microcatheter, intermediate catheter, and everything was very hard to position, because it was shortening because of the loops and the kinks. Because of the tortuosity, it was shortening. We couldn't, and we have to pass through the aneurysm to put the microcatheter for the Leo stent, Vascom. First, the stent pulled down. Then I tried. It was planned to do. We have on the third picture, fourth, we have another microcatheter that was planned to do a coiling together, jailing technique, but it fall down, and it was a little bit tricky. We couldn't pass again, and we succeed finally, and we open the Leo. I think it's a good position. This patient has another aneurysm a dissecting aneurysm of the vertebral artery with at the level of the pica origin, and we put here the flow diverter pipeline. The other case is bilateral cavernous sinuses aneurysms, big, partially thrombosed. I wanted to show you not good opening of the pipeline in this position because of the tortuosity and the primary stenosis in this petrocavernous part. And first we try to open with a J wire. It was open a little. Here is how it's looking. But after we decided to put balloon and to have a good, to ensure a good opening of the pipe all the way. You can see on this and this and this image, and after 3 days we made. I wanted to open this. After 3 days, we made. We go for the another. I don't know. It can be open. I wanted to see for you to see. It can. Okay. Here it is. Look at here, thrombosis after 3 days because of the good opening of the flow diverter, and this is the control MRI after 3 months. And the same patient, the right side after 3 days, again a little bit smaller. Here was planned jailing flow diversion with coil technique, but I was guilty because I opened whole the flow diverter pipeline before putting the coil and the microcatheter fell down, and the coil was detached, and we was pinching with the micro snare. See in the intermediate catheter, because we pull out the microcatheter and we didn't have another chance, and we pull it with the micro snare, and here is the good opening of the pipe and good result. And after 3 months control on this side, look at the good position and volar position of the pipe. This is a simple case, but the decision is here what to do. This is ruptured dissecant aneurysm of the origin of the pica, and there was a severe hematoma, intraventricular hemorrhage and everything, and there is no way, because the pica is dominant, there is no way another to treat. I was waiting, but family was not they didn't understand that we have to wait, and we do it on the 8th day, I think, and we put just a flow diversion, and look at, there is a stasis in the dissecting aneurysm, and the patient is good. She was on a control, she is perfect, but we didn't make still the imaging. This is a case of dural AVF, difficulty in trying to look at the beginning. You look, it's external, it's occipital branch, it's easy to come there, but it was very, very, very hard. We didn't succeed first from the femoral approach with the intermediate catheter and everything. We couldn't catheterize the occipital branch because of the angle. And after 2 days, we go by the radial access with normal diagnostic catheter, and we get this new gamma microcatheter from about my colleague told me about him with Simpsons and microchip 2, I think it was, and we succeed to reach this branch. But at first we put a coil in this distal branch of occipital artery to redirect the onyx to the fistula, but it was very, very fast injection of the onyx, and then it didn't penetrate so good. And after that, when we see from meningeal, medial meningeal artery, we saw the good feeling of the AV fistula, and here we go with the slow injection and reaching the venous pouch at the here, and we close the fistula. The patient is good, but it was hard. It's depends how you're advancing the onyx. And this is the spinal AVM. I can tell you it was done in two or three sessions, because it was a little bit tricky. It was bleeding with medullary hematoma, with paraplegia and monoparesis. It was like that. And first from the vertebral artery, we can see from the right vertebral artery, from the V4, we can see descending one branch that is going and feeding the AVM. But this, I think it's cervical ascendens artery that is the main feeder for this AVM, spinal, medullary. And it was easy to reach this branch. And we embolize with a good penetration. And here is the main thing, that the good penetration give us closing this descendant branch from V4. Here is the control. Because of the good penetration, we don't have any feeding from V4, from the right side. From the left side, we didn't succeed because we made trying to pass this tortuous anatomy of this feeding branch, and I forgot to tell you that here was the main feeder that was the rupture was from this ascendant cervical branch because of the aneurysm that is in that part of the AVM. From the left side, we tried to reach this tortuous anatomy, and we made it dissection, as you can see here, of the vertebral artery. But we passed and make fenestration of this dissecting flap, and we balloon it a little bit and leave the patient for 3 days, 4 days with the anticoagulant therapy. There was no new neurological deficit. It was done in all the intervention for this patient was done consciousness sedation. And after that, we decide to come with a balloon in the vertebral artery and with the proximal position of the microcatheter in this feeding branch to make the embolization with the onyx, but with the inflated balloon. I don't know where is. Here is that video before. That was the most distal part where we can go with a microcatheter because of the tortuosity. We tried so many times, but it's good result. This is that you can be sometimes. This patient came in emergency with epistaxis, sent with epistaxis. And we didn't expect, we was thinking that it will be some, I don't know, embolization with the particles or something like that of the external carotid artery, but we find pseudoaneurysm from the nasopharyngeal carcinoma. It's a young patient, 32 years old, with active bleeding. It was in a hemorrhagic shock, and we just wanted to tell you that we put the coils distally and proximal after that on this film, but still there is a feeling of the pseudoaneurysm, and we take the liquid embolic. It was lipiodol with histoacryl combination, and we close this. You can be surprised from some cases. That was my point of this case, and this is a small aneurysm that went well with the embolization, simple coiling, but zoom. When we are using zoom in, we must see on a control, on zoom out, and we can see this distal embolization, and we went with a stent retriever, and it was a bleeding aneurysm, and it went well. And this is the last case. Sorry about the time. We put the balloon in M1, M2 because of the wide neck, but we didn't expect, but we didn't inflate because it was a good, positioning of the coils, and I was again guilty, I think, because at the last coil, I decided to inflate the balloon. After finishing, and it's ruptured. And we can see how is this rupture. And we went to the operating room. I was inflating the balloon. I was putting another coil, but there was a bleeding again. And this patient went to the operating room. I wanted to tell you that I saw on a microscope, because I was in the operating room, that was atheroma, and that was dissection from the balloon. Atheroma ruptured and make this. It was dissecant. I didn't take the pictures from the microscope. I can get from another presentation. That's all I have to say. We should be aware and not over-treating small unruptured aneurysm, not chasing angiographic cure in high AVMs, overlapping too many flow diverters, and underestimate perforated. Use always good support with the intermediate, keep bailout devices always ready, and always have a surgical backup. That's all I have to say. Thank you.
Thank you for the wonderful presentation. I will say it, look on the screen till the end of the procedure, otherwise everything can happen till the end.
Everything.
Thank you. Any
you.
questions? Thank you, Menka. The next speaker, it's my good friend from Bosnia. He will speak about the teeny line between the control and the catastrophe.
Hello, thank you for your introduction, and I want to thank organizers for inviting me. It's always a pleasure to be here. And my topic for today is the fine line between control and catastrophe. So it's a bit similar to Menka's topic. However, actually, presentation is not the same. So I'm going to give you some more advices than tips and tricks in hemorrhagic neurointervention. So I have nothing to disclose in relation to this topic. And I will start the presentation with the quote of Theodore Roosevelt. The only man who never makes a mistake is the man who actually never does anything. So remember that. So we started to perform independent linear interventions in 2017 in Sarajevo. Before that, we had 9 visits from some Slovenian colleagues, and we managed to treat 32 patients before we started some simple cases in the start to do it independently. And the majority of cases were actually cerebral aneurysms, so it's the most common neurovascular affliction. Why? Because it can be treated with the excellent clinical outcomes, it provides effective protection, and yes, complications may occur, you know, but we are there to actually to foresee it and to manage it. And there are a lot of trials. These are the biggest ones. In regards to endovascular treatment of cerebral aneurysms in different ways, with coils, with flow diverters, with intrasaccular devices. Goals of endovascular therapy remain the same for 52 years, since the first report about endovascular treatment appeared in 1972. Prevent rupture, minimize morbidity, reduce recurrence, and maintain parent vessel patency. So we need to do that in order to avoid complications that can happen. And they are roughly divided into these 5 categories: thromboembolic, hemorrhagic, delayed, device-related, and access-related. And yes, they occur, but you have articles. This article is actually being written by some neurosurgeons who are not performing neurointerventional procedures. In current studies, they tend to actually over-exaggerate with the percentage of the complications. In true, if you run through the literature online, you will find incidence from 4.7 to 12.5%, being higher with the stent and flow diverters, and because of different mechanisms or faults, technical faults that you made before. However, it can be easily prevented or treated. So I'm going to jump into some of my cases. This was case actually performed in 2016 under supervision of these experts who came. And in this case, we actually did stent-assisted coiling of the small ICA aneurysm. Everything was actually okay. At least we didn't see the problem at that time. However, we were called 2 hours later, and we had thrombosis of the stent with insufficient collateral flow. So at that time, we didn't have large bore catheters, we didn't have stent retrievers, so we opted for pharmacological management. So we administered first RTPA and then continued because nothing happened with tirofiban, so we exaggerated with the dose. And at the end, actually, the thrombus melted, so additional partial telescoping was performed. The patient got lucky and she was discharged without any major neurological deficit. And this was actually 1 year follow-up, so everything looked nice at the end. So what lessons have we learned from this? This was not related to this case, but we had similar, lots of cases with vasospasm. It can diminish the flow and it is easily treatable. How can we treat it? With the routine administration of, at least in my institution, of 3 milliliters of nimodipine intraarterially after positioning long sheet in the carotid bulbus and advancing with the distal access catheter further cranially. We never start stenting without having GP2B3A on shelf and introduced to the anesthesiology team. And there's always extra pair of eyes who is monitoring the position of the base camp of the distal access catheter and analyze dynamics of the flow on the diagnostic angiograms that you're routinely doing during procedure. And for the youngsters, have a proctor close by, in person or online, when you're starting with this. According to Brzezinski, actually GP2B3A is superior in contrast to other pharmacological agents that we have on market. This is the second case. It was actually dissecting aneurysm. The patient underwent some maxillofacial surgery, so they managed to penetrate the bone and to hurt the vessel. We did emergency coiling a few days after the surgery, and then in the 6-month follow-up, we had this acute regrowth of aneurysm, and we put here, I don't know where can you see or not, it is, I think it was Fred flow diverter, so everything was okay, and the patient actually had some sort of mild neurological discomfort for 2 days before being discharged from the hospital, and he never reported until maybe 11 months after the procedure, so for the routine follow-up, and on the follow-up we saw this. So what happened actually, if you look into the struts of the stent, you can see in the proximal part there is mild twist of the stent. It altered hemodynamics through the stent, and the result was this. And it was actually obvious during the treatment. So we go back and looked at the treatment, and we saw this here, and there is no opposition of the stent here. So we didn't do anything else because he had sufficient collateral flow, so we leave it like that 1 year later. So my advice is give yourself time to carefully inspect the treatment stages during and immediately after the treatment. Another case of a female, 55 years old. We were treated 2 aneurysms, giant mirror C4 aneurysms on both sides. So first we opted for the right one. And here you can see how the base camp is actually being retracted proximally while during the final phase of unsheathing of the flow diverter, which resulted in this concordance of the width of the proximal part of the stent with the width of the vessel. Of course, we already learned from experience, so in this case we used a balloon and fixed this. So have a balloon catheter with you when you're doing intervention. So this is follow-up 1 year later. Actually, this was the stage where we decided to treat another side, the left side. And on the left side, the same, but fish mouthing actually happened on the distal part of the stent. And it's easy. You can easily solve it with the balloon catheter again. Anyone who is actually doing neurointerventions on day-to-day basis had to witness at least one case like this during their routine clinical practice. Fortunately, it's not frequent. However, when it happened, you know, it leaves a scar, mental scar to you, of course. And you can see here the percentages. It's quite infrequent in patients with unruptured aneurysm. However, the frequency tends to get higher with the ruptured cases like this one. So this happened actually 8 months ago. So ruptured aneurysm, we were on, one was on vacation, then another one. So the patient was there for, I don't know, maybe 14 days, so we waited for the vasospasm to actually begin, and then we started with the shouldering technique, so braided stent from PCA to basilar artery and some coil packing, and we actually went, okay, you cannot see, you can see the videos here, and this is what happened during the procedure, you know. So what can you do in this case? Continue with the coils and put a balloon proximally and tend to control, of course, reverse heparin. However, we actually administered some GP2B3A before, because if we go back, there was, okay, it's impossible, there was some clogging at the distal part of the braided stent, you know, and maybe that was the reason, but at the end, the message that we had for us is to buy biplane for us. And we reminded ourselves on the famous interventional saying, perfect is enemy of good. So leave it when it's good, and of course have protamine at shelf. I think it's necessary. So according to Japanese authors, heparin reversal is associated with ischemic complications. And again, anti-hypertension medication is actually associated with hemorrhagic complications. So you have to be careful about these facts when you're administering or ordering anesthesiology team to administer this to the patient. What about device-related complications? There are many, and Menka, I think, showed almost all of them. You know, and I will show you you have some anecdotal cases throughout the literature about coilectomy. So this happened almost 2 years ago. So it was balloon-assisted coiling. It was simple. It is we put 2 coils, you know, and everything looked perfectly aligned and stable until we retracted the balloon catheter, and then first prolapse of the one loop of the coil, and then everything jumped into the MCA, and this is the end result. So we used stent retriever and collect the coils with the solitaire device. Okay, I will. This was actually taken by some resident who was watching this, so you can see, of course, with the aspiration, and it was successfully. And this happened 1 month later, so we Went back again with the same patient, again with the same technique. We didn't want to change it. This time with heater coils. Everything was okay. This time we had only one loop protrusion, so it was really nice. But according to Murphy, anything that can go wrong will go wrong. This is Murphy, by the way. This is what happened. So we finished the procedure, congratulated ourselves, went and left the resident to do manual compression, and of course groin hematoma a few hours later. So we went back to angio and inflated the balloon contralaterally for a few minutes in order to control. Why we did that? Because you know how grumpy vascular surgeons are when you call them to clear your mess. So don't do it if you can do it by yourself. Another case, this happened actually under proctorship of this guy over there a few days ago. So we were super stubborn in order to actually enter the aneurysm from the right side. Eventually we gave up and we go contralaterally through the anterior communicating artery. We shaped the catheter, of course. This is one of the message here and everything. However, we had only one suitable coil on the shelf. And this coil was, first we tried on the right side and then on the left side. At the end, we were 2 loops short for the placement of the coil, and we actually ended up in almost thrombectomy. So the coil actually stuck up in the microcatheter, so we need to retract it through the anterior communicating artery. Of course, in this case, distal access catheter went all the way up to the carotid bifurcation, and at the end, it was good. So have a loaded shelf, of course, and shape your microcatheter in order to be successful. So it is highly effective, but it demands vigilance and precision. And these complications are part of our job, so we cannot escape from that. And I think the key point is actually anticipation, teamwork, and humility. These are the strongest defenses against adverse events. And every complication offers a lesson that refines your skill. So, as Oscar Wilde said, experience is the name everyone gives to their mistakes. So, remember that. And with this, I want to thank you for your attention. And I will use actually this opportunity to invite you all to come to Sarajevo. We are organizing second Congress of our International Radiology Society. It will happen from 6 to 8 November this year, and more information you can find on this webpage. Thank you.
Deniz, thank you for sharing your experience. Of course, that we should learn about through our mistakes. So
yes.
Thank you.
Yeah. In most of the cases, we are learning from ourselves, you know, and this is actually the bad way.
C'est la vie, says French. So, thank you. Thank you. Any questions? So, thank you. Let's go further. You have